Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. In this session, I will be discussing a very important topic in the cardiology, that is the congestive heart failure. So what exactly is the definition of the congestive heart failure? So it is the clinical scenario which is characterized by cardiac pump dysfunction, right? So in this individuals there will be cardiac pump dysfunction. And this particular cardiac pump dysfunction, it might be either a systolic dysfunction or a diastolic dysfunction. And because of this cardiac pump dysfunction, there is decrease in the cardiac output, right? So there is actually decrease in stroke volume, and subsequently there will be decrease in the cardiac output. And as the cardiac output is decreased, there will be also decrease in the blood pressure of the individual, and there will be decrease in the perfusion to the organs. So this is what is the exact definition of the congestive heart failure. Now, in patients with the congestive heart failure, we classify them into the stages, that is stage A, stage B, stage C and stage D heart failure. What is that? Let me discuss. So in order to explain the stages of the heart failure, right, let me just give you a clinical scenario. I have a 56-year-old man with a history of the coronary artery disease and a documented ejection fraction of 40% by echocardiography, and he presents for further management. At this visit, patient denies having shortness of breath, dyspnea on exertion, orthopnea or lower extremity edema. So the individual is asymptomatic, but he had a past history of the coronary artery disease and documented ejection fraction of 40%. And he has been admitted to the hospital for the congestive heart failure. According to the new American College of Cardiology or American Heart Association guidelines for the evaluation and management of heart failure, in what stage of heart failure does this patient belong to? Stage A, B, C and D. Now, first let me explain the various stages of the heart failure, and then let me just conclude to this which particular stage this patient belongs to. So I said you like we have stage A, B, C, D. So the individual in stage A, they are at risk of the heart failure, but they don't have any structural disease. So if you take stage A, these individuals, they are at risk of heart failure, but there is no structural heart disease. And these patients, what do they require? Primary preventive measures are very much required in stage A congestive heart failure. Now, what do you mean by the word at risk of the congestive heart failure? That is like diabetes mellitus, hypertension. These are the risk factors for the development of the congestive heart failure. But these patients, they don't have any structural disease. Whereas stage B, if you see, these are the individuals who are at risk of the congestive heart failure, and they also have the structural disease. Right, they also have the structural disease, but they don't have any heart failure symptoms. And these patients, what are the proposed therapies? These patients, they have to be given beta blockers, ACE inhibitors or angiotensin receptor blockers. Whereas stage C, if you observe, these patients, they have structural heart disease, and along with that they have the heart failure symptoms. And these patients of stage C, they require diuretics, they require the digoxin, they require the ACE inhibitors, they require angiotensin receptor blockers, and non-pharmacological treatment like implantable cardioverter defibrillator and cardiac resynchronization therapy is required for the management of the stage C patients. Then stage D, we call these patients as the advanced heart failure patients, and these individuals, they show refractoriness to the cardiac medications whatever you give. So these patients with stage D, they require the cardiac transplantation or mechanical support and inotropes. So this is about the stage D of the congestive heart failure. So going back to the clinical scenario which I have taught you or which I have said you, in this individual there is structural heart disease, right? Coronary artery disease is there and ejection fraction is 40%. Normal ejection fraction is around 55 to 60%, but this particular patient is having ejection fraction of 40%. And this individual is asymptomatic. So under which particular stage of the heart failure does this patient comes under? This patient comes under stage B congestive heart failure. Whereas stage A, at risk, no structural heart disease. Stage B, presence of structural heart disease but asymptomatic. Stage 3, the individual is symptomatic. Stage 4, end stage heart failure or there is refractoriness to the medications. So this is about the stages of the heart failure. So once the individual is about to develop the heart failure or once the individual has developed heart failure, what did I tell you? What will happen to the blood pressure of the individual? Blood pressure of the individual decreases. And what will happen to the perfusion to the organs? Perfusion to the organs will be reduced. And our body will try to activate, right? Our body will try to activate the compensatory mechanisms. Now, what are those compensatory mechanisms? So, why this particular compensatory mechanisms are activated? That is because of fall in the blood pressure of the individual and that is due to decreased perfusion to the organs. Right, that is because of fall in the blood pressure and that is due to decreased perfusion to the organs. There will be activation of the compensatory mechanisms. So, as and when there is decrease in the blood pressure, this decreased blood pressure, it is being sensed by the baroreceptors, right? So this is being sensed by the baroreceptors, right? And what are these particular baroreceptors? These baroreceptors, they include the carotid sinus receptors and the receptors in the aortic arch. So, right, carotid sinus receptors and the receptors in the aortic arch. Right, so these are the baroreceptors. And once these baroreceptors are activated, the afferent gets activated. The afferent from these baroreceptors will be the ninth and the cranial nerves which play an important role in giving the information to the medulla oblongata where there is sympathetic outflow is 9th and 10th cranial nerve. So once these baroreceptors are activated, the information is passed to the medulla oblongata saying that the blood pressure is less. And immediately the vasomotor center which is present within the medulla oblongata, it gets activated and there will be augmentation of sympathetic outflow. Right? And once there is augmentation of sympathetic outflow, there will be release of your epinephrine and norepinephrine and this will increase the blood pressure within the individual. So that is one of the compensatory mechanism in patients with the congestive heart failure which will increase the blood pressure within the individual. And the other compensatory mechanisms if you see, so in patients with congestive heart failure, what is happening to the blood pressure? The blood pressure of the individual is reduced. Now as the blood pressure of the individual is reduced, what will happen to renal perfusion? Renal perfusion is also reduced. Right, the renal perfusion is reduced. So once the renal perfusion is reduced, there is activation of renin angiotensin aldosterone system. Okay, so once the renal perfusion is reduced, remember there will be decrease in the GFR, that is glomerular filtration rate. Now once there is decrease in the GFR, the JG cells, they get activated, right? JG cells, they get activated, and this particular JG cells, they will release the renin, and this renin, it acts on angiotensinogen, and angiotensinogen is the substance which is synthesized within the liver, and this angiotensinogen is converted to angiotensin 1, and this angiotensin 1 in the presence of angiotensin converting enzyme is converted to angiotensin 2. And what this angiotensin 2 does? This angiotensin 2, it is a potent vasoconstrictor. Right, it is a potent vasoconstrictor, and that will cause increase in the blood pressure of the individual. Right, that will cause increase in the blood pressure of the individual. So that is the second compensatory mechanism, that is activation of renin angiotensin aldosterone system. Right, then if you take the third compensatory mechanism, the third compensatory mechanism is non-osmotic release of the arginine vasopressin. Right, non-osmotic release of the arginine vasopressin. So arginine vasopressin, it is also called antidiuretic hormone. So whenever there is increase in osmolality, right, whenever there is increase in osmolality, there will be release of this antidiuretic hormone or arginine vasopressin. Right, whenever there is increase in osmolality, there will be increase in arginine vasopressin or antidiuretic hormone, both are the same, and they will cause the reabsorption of the water from the distal tubules, and thereby the osmolality which is increased will return back to normal. But here in patients with congestive heart failure, there is non-osmotic release of the arginine vasopressin or antidiuretic hormone, which will cause the water reabsorption, right, which will cause the water reabsorption from the distal tubules. Right, which will cause the water reabsorption from distal tubules. So these three are the compensatory mechanisms. Number one, augmentation of the sympathetic outflow. Number two, activation of renin angiotensin aldosterone system. Non-osmotic release of the arginine vasopressin. Now, all these compensatory mechanisms, let me tell you, they are transiently, right, they are transiently useful to the individual, right, but in long term, these particular compensatory mechanisms, they will precipitate the heart failure. Now, in what way these compensatory mechanisms precipitates the heart failure, I will discuss that in detail. So, to summarize, whenever there is heart failure, there will be reduced cardiac output, and then there will be activation of baroreceptors, and that will cause increase in sympathetic outflow, and there will be decreased renal perfusion, there will be activation of renin angiotensin aldosterone system. So once there is activation of renin angiotensin aldosterone system, aldosterone is being synthesized by your RAS mechanism, and there will be increased sodium and water retention, and because of decrease in the cardiac output, there is activation of the sympathetic nervous system, and there will be increased peripheral resistance, and there will be vasoconstriction and increasing the hydrostatic pressure within the individual. So these patients with the congestive heart failure, because of the activation of compensatory mechanisms, there is increase in the hydrostatic pressure, and once there is increase in hydrostatic pressure, the fluid exudes out of the blood vessel. Right, the fluid exudes out of the blood vessel, and that will result in the edema. Right, that will result in edema. Now, after having discussed about this, if you see the clinical manifestations of the right heart failure and left heart failure, see, when we are using the terminology called congestive heart failure, It includes both right heart failure and as well as the left heart failure. Presently, we are not using the classification as whether the patient is having right heart failure or left heart failure, or whether the patient is having systolic heart failure or diastolic heart failure, or whether the patient is having high output heart failure or low output heart failure, or we don't have the classification like the high output heart failure. Presently, the classification of the heart failure is based on the ejection fraction, right? It is based on the ejection fraction. So, which tells you about the contractility of the heart. So, based on ejection fraction, we classify the heart failure as HFpEF, that is heart failure with preserved ejection fraction, and the HFrEF, that is heart failure with reduced ejection fraction. So, this is how we classify the heart failure, that is HFpEF and HFrEF. So, if you see the question, all of the following are true about the right ventricular infarcts except nocturia, hepatomegaly, ascites, the normal jugular venous pressure. So, let me discuss the features of right heart failure and then come back to this question. So, now what will be the earliest, right, what will be the earliest sign of right heart failure? The earliest sign of right heart failure is raised JVP, right? The earliest sign of right heart failure is the raised JVP. That will be the earliest sign. And why is this particular JVP being raised and what is the mechanism? All that let me discuss in detail. So, consider this to be a 4-chambered heart, and this is the tricuspid valve, and this will be the mitral valve. And into the right atrium there is opening of superior vena cava and there is opening of the inferior vena cava. So whenever there is right heart failure, the output from the right heart into the pulmonary artery will be reduced, right? The output from the right heart into the pulmonary artery will be reduced. So there will be increase in the volume of the blood in the right ventricle because the right ventricle is failed. So thereby what will happen to the pressure within the right ventricle increases, right ventricular end diastolic pressure increases. So when the right ventricular end diastolic pressure increases, subsequently there will be increase in the pressure in the right atrium because right atrium is unable to empty the blood into the right ventricle. Now as the pressure in the right atrium increases, subsequently there will be increase in the pressure within the superior vena cava and as well as the inferior vena cava. Now if you take this superior vena cava is the structure like which receives the blood from upper half of the body, and it is the jugular vein which will drain the blood into the superior vena cava. So once the pressure within the superior vena cava is increased, subsequently there will be increase in the pressure within the jugular vein. So that is what is called the raised jugular venous pressure, and that will be the earliest sign. And the other important features is that into the inferior vena cava there will be opening of the hepatic veins, right? The hepatic veins, it will take the venous blood from the liver and they will drain into the inferior vena cava. Now the blood which has entered into the inferior vena cava has to enter into the right atrium, but in patients with a congestive heart failure there is increase in the right atrial pressure, and once there is increase in right atrial pressure, subsequently there will be also increase in the pressure within the inferior vena cava. So when the pressure within the inferior vena cava is increased, the hepatic veins, they are unable to drain the blood into the inferior vena cava. So thereby there will be hepatic venous congestion within the liver. So thereby what will happen to the size of the liver? The liver, it gets enlarged. Right? And whenever the liver is getting enlarged or whenever the liver is increasing in its size, what happens is liver, it is surrounded by a capsule, right? It is surrounded by the Glissen's capsule. Okay, so when liver is enlarged, the capsule which is present around the liver, right? The capsule which is present around the liver, it is tightly stretched, right? It is also being enlarged, and this particular capsule, it is pain sensitive structure, right? This capsule, it is a pain sensitive structure. So when liver is enlarged, the capsule is also being stretched, and thereby the individual will have severe tenderness, right? So there will be a tender hepatomegaly, right? There will be a tender hepatomegaly. That is what you will see in patients with the right heart failure. And the another important feature is that this inferior vena cava, it will be receiving the blood from the lower limbs. So when the pressure in the inferior vena cava is increased, the lower limb veins, they cannot drain the blood into the inferior vena cava. So thereby what will happen to the hydrostatic pressure in the lower limb veins? The hydrostatic pressure within the lower limb veins increases. So once the hydrostatic pressure within the lower limb vein increases, the fluid from the lower limb veins will move out of the veins, and that will get accumulated outside the veins, and that will result in what is called the pedal edema. Right, that will result in what is called pedal edema. So there will be bilateral pitting pedal edema, right? There will be bilateral pitting pedal edema. So that will be the three important features: raised JVP, tender hepatomegaly, bilateral pitting pedal edema. These three are the important features of the right heart failure. Now, next to these features, what are the other features of the right heart failure? So if you see, this is the four-chambered heart, tricuspid valve, and then mitral valve, and into this right atrium, the inferior vena cava opens, right? And as I have said you that liver through the hepatic veins, it drains the blood into the inferior vena cava, and liver, it receives the blood liver, it receives the blood through the portal vein, right? So through the porta hepatis, the portal vein drains the blood into the liver. And just now what did I tell you? There is congestive hepatomegaly. The pressure within the liver is increased because liver is unable to drain the venous blood into the hepatic veins. So subsequently, the portal vein is unable to drain the blood into the liver, and thereby the portal venous pressure increases, and that will make the individual to develop portal hypertension, right? That will make the individual to develop portal hypertension. So as there is development of portal hypertension, the fluid, it will start moving out of the vessel, right? The fluid, it will start moving out of the vessel. So once the fluid starts moving out of the vessel, that will result in the development of ascites, right? That will result in development of what is called ascites. So ascites, it is because of increase in the portal venous pressure. And portal vein, how is it formed? It is the splenic vein and as well as the superior mesenteric vein, which will drain the blood into the portal vein, right? So as the portal venous pressure increases, the pressure within the splenic vein also increases, and subsequently what will happen to the size of the spleen? The size of the spleen increases. So the individual will develop what is called splenomegaly, right? The individual will develop what is called splenomegaly. Why is that? Because the spleen is unable to drain the blood into the splenic vein because there is increase in the pressure within the splenic vein, and that will result in what is called the splenomegaly. And at the same time, the pressure within the superior mesenteric vein is also increased, right? And superior mesenteric vein, it will drain the blood from the GAT, right? Superior mesenteric vein, it drains the blood from the GAT. So once the pressure within the superior mesenteric vein increases, right? Once the pressure within the superior mesenteric vein increases, let me tell you, the GIT cannot drain the blood into the superior mesenteric vein, and that will result in the GI wall edema, right? That will result in the GI wall edema. So once there is gastrointestinal wall edema, the absorption of the nutrients across the GIT does not occur, and thereby there will be nausea, and as well as they can also have the vomiting, right? They also have the development of the vomiting. And the next important feature is that there will be weight gain within the individual. So why is that they have weight gain? That is because of the fluid overload. There will be weight gain within the individual, right? These individuals with right heart failure, they also have a positive hepatojugular reflex. Right, they also have positive hepatojugular reflex. So regarding the hepatojugular reflex, I have discussed that in detail when I am discussing the jugular venous pressure or jugular venous pulse. What is that? When you apply the pressure over the right hypochondrium, there will be increase in the JVP, and whenever you remove the pressure, the JVP has to return back to normal. That is, jugular venous pulse has to return back to normal. But here in positive hepatojugular reflex, in spite of removing the pressure from the right hypochondrium, the jugular venous pulse, it is raised above 3 centimeters, and that will be sustained. Even removing the pressure on the right hypochondrium will not make the JVP to return back to normal. That is what is called a positive hepatojugular reflex, right? And the next important feature in case of the right heart failure is development of nocturia. Right, development of nocturia. So nocturia is that, like, where there is increase in the urine output mainly during night. So why is that they have nocturia? That is because when the individual lies in supine position during night, there is increase in the venous return. So once there is increase in venous return, the cardiac output will increase, and thereby renal perfusion increases. And once the renal perfusion increases, the GFR increases, and there will be nocturia. Right? So the entire fluid which is accumulated in the form of pedal edema, the fluid which is accumulated in the form of ascites, all that will try to enter into the venous system, and the venous return increases during night, and thereby there will be nocturia. So these are the features of right heart failure. So the earliest sign will be raised JVP, and the other important features are tender hepatomegaly and as well as the pedal edema. The other features include the development of the ascites, splenomegaly, nausea and vomiting, weight gain, nocturia, and there will be also positive hepatojugular reflex. Now, after having discussed about the features of right heart failure, let me tell you the features of the left heart failure. So, if you observe the features of the left heart failure, so this will be the 4-chambered heart. So, in left heart failure, what happens? The cardiac output into the aorta will be reduced. Right? Cardiac output into the aorta will be reduced. So, thereby, what will happen to left ventricular end-diastolic pressure within the left ventricle? The left ventricular end-diastolic pressure within the left ventricle is increased. So, as the pressure within the left ventricle increases, subsequently, there will be increase in the pressure within the left atrium, right? Subsequently, there will be increase in the pressure within the left atrium. So, as the pressure within the left atrium increases, the pressure within the pulmonary veins also increases, right? As the pressure within the left atrium increases, the pressure within the pulmonary veins also increases. So, as the pressure within the pulmonary veins increases, subsequently, there will be increase in the pulmonary capillary wedge pressure, right? Subsequently, there will be increase in the pressure within the pulmonary capillaries, and that we call it as increased pulmonary capillary wedge pressure. So, as the pulmonary capillary wedge pressure increases, the fluid from the pulmonary capillaries enters into the lungs, resulting in what is called the pulmonary edema. right, resulting in what is called pulmonary edema. So in patients with left heart failure, there will be raised pulmonary capillary wedge pressure resulting in the development of pulmonary edema. So once there is development of pulmonary edema, right, once there is development of pulmonary edema, these individuals, they develop dyspnea, right? But what will be the earliest manifestation in patients with the left heart failure? The earliest manifestation in patients with left heart failure will be development of paroxysmal nocturnal dyspnea. And what do you understand by this word, paroxysmal nocturnal dyspnea? It means that these individuals, when they sleep, initially they don't have dyspnea, but there will be development of dyspnea after, right, there will be development of dyspnea after 2 to 4 hours of sleep. Right, there will be development of dyspnea after 2 to 4 hours of sleep. That is what is the paroxysmal nocturnal dyspnea. And as the severity of the left heart failure increases, the individual from the stage of paroxysmal nocturnal dyspnea will progress to the development of orthopnea. Right, the individual will progress to the development of the orthopnea. So there will be paroxysmal nocturnal dyspnea, and later there will be orthopnea. Orthopnea is like the individual will have dyspnea in supine position. And from the stage of orthopnea, the individual will go to the stage of dyspnea on exertion, and in severe left heart failure, they'll have dyspnea at rest. So that will be the features of the left heart failure. And in patients with left heart failure, please remember there is increase in the pulmonary capillary wedge pressure. So if you see the normal pulmonary capillary wedge pressure, normal pulmonary capillary wedge pressure, it is around 6 to 12 millimeters of mercury. But in these individuals, the pulmonary capillary wedge pressure will be more than 18 millimeters of mercury, right? So that is about the features of the left heart failure. But if you see in right heart failure, in patients with right heart failure, the pulmonary capillary wedge pressure, it remains normal. Right? Pulmonary capillary wedge pressure will be normal in right heart failure. Okay, next. Now, after having discussed about the features of right and as well as left heart failure, let me, go back to the question like which I have said you in the beginning. All of the following are true about right ventricular infarcts except, see, these patients with the right ventricular infarcts, they land up in right heart failure. So once they develop right heart failure, what did I tell you to the JVP? The JVP, it gets elevated. So they will not have the normal JVP. They will have nocturia, they will have hepatomegaly, and they will also have ascites. But the JVP will not be normal. The JVP will be elevated. So there will be raised JVP in the right heart failure. Next, all of the following are the features of right-sided heart failure except increased pulmonary capillary wedge pressure, pulsatile liver, increased JVP, positive hepatojugular reflex. So in this, the answer is, the question is except. They will not have increased pulmonary capillary wedge pressure. Increased pulmonary capillary wedge pressure, it is the feature of the left heart failure. Right, it is the feature of the left heart failure. And the remaining three, they are the features of the right heart failure. Right, remaining three, they are the features of the right heart failure. Now, after having discussed about this, you see the next question. Enlarged pulsatile liver, right, enlarged pulsatile liver with ascites is typically seen in, right, enlarged pulsatile liver with ascites is typically seen in tricuspid regurgitation, mitral regurgitation, mitral stenosis, the pulmonary stenosis. So enlarged pulsatile liver with ascites, it is typically seen in patients with the tricuspid regurgitation. Now, what will be the typical physical examination findings in the tricuspid regurgitation? So these patients with tricuspid regurgitation, ultimately they land up in the right heart failure. right? Ultimately, they'll end up in the right heart failure. So once there is development of right heart failure, right? Once there is development of right heart failure, there will be raised JVP, right? And there will be development of ascites, right? And there will be development of the pedal edema. Right, there will be development of pedal edema. And they also have the hepatomegaly. But this particular hepatomegaly that you will observe in right heart failure will be pulsatile hepatomegaly. Right, that will be pulsatile liver. Right, there will be enlarged liver. And these pulsations are mainly during systole. So there will be systolic pulsations within the liver. So why is that they have the systolic pulsations within the liver? Because in tricuspid regurgitation, the blood from the right ventricle will enter into the right atrium during the systole of the right ventricle. So during the systole of the right ventricle, in tricuspid regurgitation, the pressure within the right atrium is increasing. And that increased pressure within the right atrium, it will reflect back onto the liver, resulting in the systolic pulsations within the liver. So they will have hepatomegaly with a pulsatile liver, right? So there will be enlarged tender liver with systolic pulsations, right? And they also have a positive hepatojugular reflex, right? They also have a positive hepatojugular reflex. And if you see the JVP in the tricuspid regurgitation, what are the abnormalities within the waves? They have prominent V wave and they have early Y descent. Right, they have early Y descent. So that will be the JVP findings in patients with the tricuspid regurgitation. And when you auscultate these patients, right, when you auscultate these patients with the tricuspid regurgitation, they have a characteristic pansystolic murmur, right? PSM stands for pansystolic murmur or holosystolic murmur. And this pansystolic murmur or holosystolic murmur, it is present along the lower left sternal margin. Right, it is present along the lower left sternal margin. And this pansystolic murmur, it increases on inspiration. Right, this particular pansystolic murmur, it increases on inspiration. Right, so that is about the features of the tricuspid regurgitation. Then, so enlarged pulsatile liver with ascites is typically seen in the tricuspid regurgitation. Next. Followed by that, the next important question, if you see, increased hydrostatic pressure in left-sided congestive heart failure causes raised JVP, congestive hepatomegaly, pedal edema, and then the orthopnea. So, raised JVP, it is the feature of, right, it is the feature of the right heart failure. Congestive hepatomegaly, that is also the feature of the right heart failure. And pedal edema, even this is also the feature of the right heart failure. But if you see the orthopnea, this is the feature of the left heart failure. So left-sided congestive heart failure, it will cause increase in the pulmonary capillary wedge pressure. Right, this will cause increase in the pulmonary capillary wedge pressure. So as there is increase in pulmonary capillary wedge pressure, that will make the individual to progress to the development of the left-sided heart failure. So increase in hydrostatic pressure in left-sided congestive heart failure causes the left heart failure. That will lead to increase in pulmonary capillary wedge pressure and that will lead to the development of orthopnea. Next. Peripheral edema in congestive cardiac failure is due to increase in sympathetic tone, atrial and natriuretic pressure, increase in hydrostatic pressure, pulmonary hypertension. See, the correct answer will be increase in hydrostatic pressure. But this increase in hydrostatic pressure, it is due to increase in the sympathetic tone as well. So the best answer will be C, but even A also can be taken as the answer to this question. Next, now if you see the dyspnea, right, in patients with the left heart failure, we have discussed that there will be dyspnea. And this dyspnea, the severity of the dyspnea is being classified by the NYHA, that is New York Heart Association. And the question is, inability to carry out, right, inability to carry out any physical activity without discomfort comes under NYHA class 1, NYHA class 2, 3 and 4. So let me discuss, right, the NYHA classification 1, 2, 3, 4. So if you take this NYHA class 1, NYHA class 1, there is no limitation of the physical activity. But first of all, I want to tell you that this NYHA classification, it not only tells you about the dyspnea, right, it not only tells you about the dyspnea. Apart from the dyspnea, the other parameters that are taken into consideration in the NYHA classification is even the fatigue. That is because in patients with left heart failure, there is decreased cardiac output and thereby perfusion to the organs will be reduced, and that makes the individual to develop fatigue. And the other parameter which is described in the NYHA classification is even the palpitations, right, even the palpitations, and then the dyspnea. These three parameters we explain under the NYHA classification. Remember, it is not just only for dyspnea. And if you take class 1, in this individual, there is no limitation of the physical activity. Right, there is no limitation of the physical activity. So ordinary physical activity does not cause fatigue, does not cause palpitation, does not cause the dyspnea. Whereas in NYHA class 2, there will be a slight limitation of physical activity. Right, there will be slight limitation of the physical activity. That is, these individuals, they are comfortable at rest. But ordinary activity will result in fatigue, palpitation, dyspnea, right? So ordinary activity. Right, ordinary activity will cause dyspnea, fatigue or palpitations. And if you take NYHA class 3, these individuals, they have marked limitation of the physical activity. Right, there will be marked limitation of the physical activity. That is the NYHA class 3. These patients, they are comfortable at rest. Right, these patients, they are comfortable at rest, but less than ordinary activity. Right, but less than ordinary activity, it causes fatigue, palpitations or dyspnea. That will be NYHA class 3. And NYHA class 4, these individuals, they are unable to carry out any physical activity. Right, they are unable to carry out any physical activity without discomfort. These individuals, they develop the symptoms of cardiac insufficiency at rest, right? So even at rest, they have the symptoms of the cardiac insufficiency. That will be your class 4 NYHA. So class 2 we call it as mild. Class 3 we call this as moderate. And class 4, right, this we call it as the severe form of the congestive heart failure, where the individual is unable to carry out any physical activity without discomfort. So that is about the classification of the dyspnea, fatigue, palpitations according to NYHA classification. And we have one important periodic breathing that is called the Cheyne-Stokes breathing. Cheyne-Stokes breathing is seen in the intracranial hypotension, congestive heart failure, left atrial myxoma, Pickwickian syndrome. See, Cheyne-Stokes breathing, it is a periodic breathing where the individual has rapid breathing followed by apnea. So you can see that here there is rapid breathing, then followed by that there will be apnea, that is cessation of respiration. And this is an irregular respiration. And in which clinical conditions you have this Cheyne-Stokes breathing, right, where there is rapid breathing followed by apnea, rapid breathing followed by that apnea. This abnormal pattern of breathing, in which breathing is absent for a period and then rapid for a period, right, this can be seen in patients with the congestive heart failure. This can be seen in patients with stroke, right, that is bihemispheric damage. Right, and third important will be traumatic brain injuries and brain tumor. Right, traumatic brain injuries and brain tumor. And healthy people during sleep at high altitude. Right, healthy people during sleep at high altitude. And the other important cause for this Cheyne-Stokes breathing is toxic metabolic encephalopathy. And this toxic metabolic encephalopathy, it can be seen in scenarios like carbon monoxide poisoning. So these are all the conditions where you have the presence of the Cheyne-Stokes breathing, right? And so if you see this question now, Cheyne-Stokes breathing, it is seen in patients with the congestive heart failure. Now, for the description of the congestive heart failure, or for diagnosing congestive heart failure, we have a criteria. And the name of that particular criteria is the Framingham's criteria. Which of the following is not a major Framingham criteria in congestive heart failure? Cardiomegaly, paroxysmal nocturnal dyspnea, S3 gallop, hepatomegaly. See, this is how the question can be framed. So for that, you need to know the Framingham's criteria. See, according to the Framingham heart study criteria for heart failure, we have the major criteria, and then we have the minor criteria. Right, we have the major criteria and as well as the minor criteria. So what are the major criteria and what are the minor criteria? We have n number of, we have exceptionally good number of the features under major and as well as minor criteria. So all that to remember, let me just give you a mnemonic. So if you take the major criteria, the mnemonic is 3 C's and then D, E, F, G, H. So now what are these three C's? C, first one stands for crackles. Right? And why is that they have this crackles? That is because of the pulmonary edema. Right? That is because of the pulmonary edema, there will be crackles or rolls within the lungs. And the other C is the central venous pressure. So central venous pressure, it is raised. Right? There will be increased neck vein distension, and that is because of the right heart failure. And another C stands for cardiomegaly on the chest X-ray. Right? Cardiomegaly on the chest X-ray. D stands for dyspnea, that is paroxysmal nocturnal dyspnea. Right? Paroxysmal nocturnal dyspnea. E stands for the edematous lungs. Right? E stands for edematous lungs, and that is pulmonary edema. Right? That is pulmonary edema. And F stands for fall of the weight in the individual. And how much will be the fall of weight? That will be more than 4.5 kgs in 5 days. Right? That will be more than 4.5 kgs in 5 days in response to diuretics. See, whenever you are giving diuretics, the fluid is completely drained out, and that will cause fall in the weight of the individual. And the word G stands for gallop rhythm. So these patients with the congestive heart failure, they have the gallop rhythm, that is S3, right? That is an additional heart sound. And why there will be an S3 in patients with congestive heart failure, I have explained that in detail in the description of the heart sounds. And the another H, the H stands for the hepatojugular reflex being positive. Right? The hepatojugular reflex being positive. So this will be the mnemonic for the features of the congestive heart failure according to the Framingham's major criteria. Then we have the minor criteria according to the Framingham's, and that particular minor criteria, the mnemonic is MNOPQRS. The word M stands for megaly of the liver. Right? And that will be hepatomegaly. The word N stands for night cough. Right? The word N is the night cough. Why is this night cough? That is because of increase in the venous return, and subsequently there will be interstitial edema, and thereby there will be night cough. And the O will be edema, but here edema is not pulmonary edema. Pulmonary edema will be your major criteria, but whereas the edema here will be ankle edema or the pedal edema. And the word P is the pleural effusion. Right? And the word Q stands for quantitative, right? Stands for quantitative pulmonary function test, where the vital capacity, right? Vital capacity is reduced by 1/3 of maximum. Right? Vital capacity is reduced by 1/3 of maximum. And the word R will be a rapid pulse. Right? Where the individual will have tachycardia, where the heart rate of the individual will be more than 120 per minute. And the word S is shortness of breath on exertion. Right, shortness of breath on exertion or the strenuous exercise. So this will be the minor criteria. Now going back to the question which I have shown you in the beginning, all of the following is not the major criteria in congestive heart failure, the except. So the presence of cardiomegaly is the major criteria. Paroxysmal nocturnal dyspnea is also a major criteria. S3 gallop is also a major criteria. But hepatomegaly, that will be the minor criteria. So now let me tell you the diagnostic criteria. Right, I have discussed major and minor, but let me tell you what is the diagnostic criteria. So if you observe or if you see the diagnostic criteria is that the presence of, right, the presence of two major criteria, right, the presence of two major criteria or one major, right, one major plus two minor criteria. Right, two major or one major plus two minor criteria. That will be the diagnostic criteria for congestive heart failure according to the Framingham's. Now, after having discussed about the diagnostic criteria and after having discussed about the clinical features of both right and as well as left heart failure, let me discuss the etiology of the heart failure. So, if you see a question, most common cause of the acute right ventricular failure: massive pulmonary embolism, tricuspid stenosis, pulmonary stenosis, tricuspid regurgitation. So if the question is asked most common cause of the acute right heart failure or acute right ventricular failure, that will be the massive pulmonary embolism. And what is the most common cause of chronic right heart failure? The most common cause of the chronic right heart failure will be COPD. Right, that is chronic obstructive pulmonary disease. And if you see what are the other causes of right heart failure, right, other causes of the right heart failure. The other causes of right heart failure includes the tricuspid regurgitation, pulmonary hypertension, right, pulmonary hypertension, and then pulmonary stenosis. These are all the other causes for the right heart failure. Now, how does the COPD cause the right heart failure? That is by the development of the cor pulmonale. Now, what is this cor pulmonale or how do you explain this cor pulmonale? Let me discuss. So, if you see this cor pulmonale, so cor pulmonale is a clinical condition which is characterized by right ventricular dilatation, right, which is characterized by right ventricular dilatation with or without right heart failure, okay, right ventricular dilatation with or without right heart failure, secondary to pulmonary vascular, right, secondary to pulmonary vascular or pulmonary pathology. Right, secondary to pulmonary vascular or pulmonary pathology. That is what is the definition of the cor pulmonale. Right, it is the right ventricular dilatation with or without right heart failure, secondary to pulmonary vascular or pulmonary pathology will be the carpal nail. Right? Now, after having discussed about the etiologies of right heart failure, now let me discuss the etiology of the left heart failure. And the etiology of the left heart failure is classified based on the ejection fraction, right? Based on the ejection fraction. So this we classify it as the heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, right? Heart failure with reduced and heart failure with preserved ejection fraction. So the normal ejection fraction, right? So this I have said you, the normal ejection fraction will be 55 to almost up to 70%, right? It is not even 60%, it can be even up to 70% also, right? 55 to 70%. So when we are using the word heart failure with reduced ejection fraction, here the ejection fraction will be less than 40%. And when we are using the word heart failure with preserved ejection fraction, here the ejection fraction will be more than 50%. Reduced ejection fraction less than 40%. Preserved ejection fraction, the ejection fraction will be more than 50%. Now, what are the conditions, right? So this reduced ejection fraction, this we call it as the systolic heart failure. Right, this we call it as the systolic heart failure, because in reduced ejection fraction the contractility of the heart will be reduced and that will make the individual to develop what is called systolic heart failure. Whereas if you take the preserved ejection fraction, the contractility of the heart is preserved, right? In preserved ejection fraction the contractility is preserved and this we call it as diastolic heart failure. Right, this we call it as the diastolic heart failure. Okay, now if you take this diastolic heart failure or the systolic heart failure, you have the features of the left heart failure, right? And subsequently, and one more question, one more point I have to tell you here at the point of the right heart failure. If the question is asked, what is the most common cause of right heart failure? Most common cause of right heart failure will be the left heart failure, right? Most common cause of right heart failure will be the left heart failure. Okay, so this is a very important point that you need to know, right? Whenever there is left heart failure, there will be increase in your pulmonary venous pressure, subsequently there will be increase in pulmonary capillary wedge pressure, and subsequently there will be increase in pulmonary artery pressure, and there will be increased afterload on the right ventricle, and thereby there will be right heart failure. So most common cause of the right heart failure will be your left heart failure. Okay, next. Now having said that, yeah, regarding the left heart failure, I have said you the types, that is HFrEF and HFpEF. HFrEF is systolic heart failure and HFpEF is a diastolic heart failure. Now after having said about the systolic and as well as the diastolic heart failure, that is HFrEF and HFpEF, what are the etiologies of HFrEF and what are the etiologies of the HFpEF? That includes the following. So if you take the etiology of the HFrEF, that is heart failure with reduced ejection fraction. So here the ejection fraction is how much? Less than 40%, right? Less than 40%. And these etiologies, they include coronary artery disease. So coronary artery disease like myocardial ischemia and myocardial infarction, the blood supply to the myocardium is reduced. So once the blood supply to the myocardium is reduced, the contractility of the heart is reduced and that will make the individual into heart failure with reduced ejection fraction. Then individuals with chronic pressure overload. So what are the conditions where you have the chronic pressure overload? You will come across this in patients with aortic stenosis, you will come across this in patients with hypertension. So these are the chronic pressure overload conditions. Then chronic volume overload condition. So if you see the chronic volume overload conditions, that includes mitral regurgitation and as well as the aortic regurgitation. These are the chronic volume overload conditions. Then cardiomyopathies. And which type of cardiomyopathy? That is the dilated cardiomyopathy, which will cause the heart failure with reduced ejection fraction. And then we also have certain infectious conditions, and these infectious conditions include the Chagas disease and then viral infections. Right, Chagas disease and then the viral infections. So these are the etiologies causing the heart failure with reduced ejection fraction. Now let me tell you what are the conditions where you have the heart failure with preserved ejection fraction. So preserved ejection fraction means where the ejection fraction is more than 50%. So this heart failure with preserved ejection fraction, you will see that in patients with cardiomyopathies, that will be the restrictive cardiomyopathy and then the hypertrophic cardiomyopathy. So basically these cardiomyopathies in early stages, they will have the development of the diastolic heart failure, which is nothing but your HFpEF, and ultimately they will land up in the HFrEF, that is heart failure with reduced ejection fraction. And the other etiologies include the fibrosis of the myocardium and then endomyocardial disorders. Then even with aging, right, even with aging there will be development of the heart failure with preserved ejection fraction, and pulmonary heart diseases like cor pulmonale, right, cor pulmonale. So these are all the etiologies which will cause the HFpEF, that is heart failure with preserved ejection fraction. So after having discussed about the etiology, so I have said you the etiology of right heart failure, etiology of the left heart failure. Now let me take up the discussion of investigations in these patients with the congestive heart failure. The question is, the radiological features of the left ventricular heart failure are all except Kerley B lines, cardiomegaly, oligemic lung fields, increased flow in the upper lobe veins. So the question asked is except. Now let me discuss what will be the chest x-ray features. I will also show you the x-rays and then we will come back to this question once again. So the features in congestive heart failure on x-ray is mainly because of the pulmonary venous hypertension. So once the pulmonary venous pressure increases, subsequently there will be increase in pulmonary capillary wedge pressure, and thereby the fluid from the pulmonary capillaries will enter into the lung, resulting in the interstitial edema and then the alveolar edema. So in the order of appearance with increasing pulmonary venous pressure, number one, there will be vascular redistribution, wherein there will be upper lobe venous distension. Right, so this upper lobe venous distension, that will be the earliest chest x-ray finding in patients with the left-sided heart failure. And from that, the pressure within the pulmonary capillary increases and the fluid from the pulmonary capillaries will enter into the interstitium of the lung, and that will result in interstitial edema. And this interstitial edema will be represented on the chest x-ray in the form of the Kerley B lines. Right, so where you have that fluid in the interstitium and that is being present in the form of lines, that is called Kerley B lines, and Kerley B lines are those which are present at the base of the lung. Then we have the alveolar edema. So that is the fluid from the interstitium will enter into the alveoli and that will result in alveolar edema. And whenever there is alveolar edema, there will be airspace opacities, right? There will be development of airspace opacities, and then there will be perihilar batwing distribution, and this perihilar batwing distribution, right, it is the accumulation of the fluid in the lung parenchyma. And this fluid which is accumulated with the lung parenchyma, it clears rapidly with diuretics. Right, it clears rapidly with diuretics. And from the state of alveolar edema, the fluid from the alveoli will enter into the pleural space, resulting in the pleural effusion. So this will be the chest X-ray findings in patients with the congestive heart failure. So I'll show you a question. Which chest X-ray is suggestive of increased pulmonary venous pressure? So, right, now you see these X-rays. These are all the X-rays of the pulmonary venous hypertension only. That is, these are all the X-rays in patients with left-sided heart failure. What is that first I said? There will be upper lobe vein distension. So you can see that here. The upper lobe venous distension. This will be the first important, the chest X-ray finding. And from the, as the severity of the left-sided heart failure increases, the fluid from the pulmonary capillaries enter into the lung, into the interstitial space, resulting in interstitial edema, and that will give rise to your Kerley B lines. Right, that will give rise to your Kerley B lines, where the fluid is accumulated at the base of the lung. And then subsequently, the fluid from the interstitium will enter into the alveoli, resulting in the alveolar edema. So this will be your, right, this will be the presence of bilateral alveolar infiltrates, right, where the individual has alveolar edema, and that is called airspace opacities. So this will be your alveolar edema, right, and subsequently the fluid from the alveolus will enter into the pleural space, resulting in the pleural effusion. Right, resulting in pleural effusion. So which chest X-ray is suggestive of increased pulmonary venous pressure? Right, A, B, C, D. So that will be the first option, right? So because of increase in the pulmonary venous pressure, there will be dilatation of the upper lobe veins. So the answer is C. Now, after having discussed about the chest X-ray picture in patients with the congestive heart failure, see, Kerley B lines I have said, that is the accumulation of the fluid within the interstitium at the base of the lung. And these Kerley B lines, they are also known as, right, they are also known as the septal lines. Right, they are also known as the septal lines. And these particular septal lines, they represent the dilated lymphatics, right, they represent the dilated lymphatics and distended interlobular septa. Right, distended interlobular septa. So that is what is the representation of the Kerley B lines. And we also have the Kerley A lines. Kerley A lines, the word A stands for apex. The word B stands for base. B lines, they are most commonly seen rather than the A lines or C lines. C lines are the lines which are present in the central region of the lung. Now, when is that you will have the presence of the upper lobe vein distension? See, the upper lobe venous distension, right? The upper lobe venous distension will be there when the left atrial pressure is increased to more than 20 millimeters of mercury. Right, when the left atrial pressure is increased to more than 20 millimeters of mercury, that is the point when there will be upper lobe venous distension. Right, now after having discussed about the chest X-ray picture in patients with the congestive heart failure, so going back to the question, radiological features of left ventricular heart failure are all except Kerley B lines, cardiomegaly, oligemic lung fields, increased flow in the upper lobe veins. So the answer here is the oligemic lung fields. So oligemic lung fields will not be there in these individuals with the left ventricular heart failure. The lung is completely loaded with fluid, right? So they will not have the oligemic lung fields. They'll have Kerley B lines, they'll have cardiomegaly, and there will be increased flow in the upper lobe veins. Now, after having discussed about the chest X-ray, let me discuss about the cardiac biomarkers. So what are the cardiac biomarkers that are most commonly used in the diagnosis of the heart failure? So assay of which of the following biomarker is most commonly used in the diagnosis of the heart failure? Brain natriuretic peptide, atrial natriuretic peptide, endothelin 1, adrenomedullin. So if you see the discussion of the biomarkers which are taken into the discussion is, that is the levels of, right, that is the levels of brain natriuretic peptide, levels of the endothelin 1, levels of atrial natriuretic peptide, and levels of adrenomedullin. All these are increased in patients with the heart failure. Right, all these are increased in patients with the heart failure, and out of which you take the BNP, that is brain natriuretic peptide. Brain natriuretic peptide, it has scored over others in prognostic, diagnostic and therapeutic value. So this is the best marker, right? It has prognostic value, it has the diagnostic value, and it also has the therapeutic value, and has also found place in guidelines for diagnosis of the congestive heart failure. And this particular brain natriuretic peptide, the assays of brain natriuretic peptide, they are commercially available and they are used clinically for screening and diagnosis of the heart failure. So this is useful for screening and this is useful for screening and diagnosis of the heart failure, and it will also predict the severity of the condition. This will also predict the severity of the condition, and it will also estimate the prognosis. It will also estimate the prognosis, and this brain natriuretic peptide, it is a neurohormone it is a neurohormone released from ventricular myocytes. Released from the ventricular myocytes in response to the myocyte stress. In response to the myocyte stress, the ventricular myocytes, they will release this brain natriuretic peptide. And this brain natriuretic peptide, it is released as a prohormone. right? It is released as a prohormone, and this brain natriuretic peptide which is released as a prohormone, it is cleaved into, right, it is cleaved into N-terminal pro-BNP, right, it is cleaved into N-terminal pro-BNP and brain natriuretic peptide, right? So this is how your brain natriuretic peptide is released from the ventricular myocytes. And this brain natriuretic peptide, as the word itself tells you, it will cause natriuresis, right? What does this brain natriuretic peptide does? It will cause natriuresis, right? It will cause natriuresis and decreases the activity of the sympathetic nervous system. Right, decreases the activity of the sympathetic nervous system, right? So both of these, your NT-proBNP and as well as the BNP, both of them, they have the prognostic value in the heart failure, right? Both of them, they have the prognostic value in heart failure, and those with higher value on admission, right? Those individuals with higher value on admission, right, those with higher value on admission, they do worse, and those whose values decrease after treatment, they have the better prognosis. But in individuals with higher values not reducing, they do or they have the worst prognosis, right? And out of your brain natriuretic peptide and NT-proBNP, right, between these two molecules, see, actually it is being released as a neurohormone and as a prohormone, and that will be cleaved into BNP and NT-proBNP. This NT-proBNP, it is superior to the BNP, right? This NT-proBNP, it is superior to BNP in predicting the hospitalization and death in heart failure. These markers are also used as independent mortality predictors, right? They are used as independent mortality predictors, right? These are used as independent mortality predictors in patients with the congestive heart failure. And what is the normal value of your NT-proBNP? The normal value of NT-proBNP is less than 300 picograms per ml. This will be the normal value of the NT-proBNP. So, if you see this question now, which of the following biomarker has been shown to correlate with the pulmonary vascular resistance in patients with heart failure is BNP, ANP, endothelin 1, endothelin 2. So, the answer is the BNP, that is brain natriuretic peptide. And what about the discussion on the other cardiac biomarkers? So, if you take the ANP, atrial natriuretic peptide, this is released from the atrial myocytes. Right, this is released from the atrial myocytes in response to the atrial stretch. Right, in response to the atrial stretch, or in response to fluid overload of the atria, there will be release of the atrial natriuretic peptide. And regarding BNP, we have discussed that in detail. And endothelin, it is released from the endothelial cells. Right, endothelin, it is released from the endothelial cells. Now this endothelin, we have endothelin 1 and as well as the endothelin 2. if you see this question here, the question is, right, the question is, which of the following biomarker has been shown to correlate best with pulmonary vascular resistance? This is a different question than previous. Shown to correlate best with pulmonary vascular resistance in patients with the heart failure. This is a very important question. The biomarker which correlates best with the pulmonary vascular resistance in patients with the heart failure will be endothelin 1, right? This endothelin 1 levels, they have been found to correlate best with pulmonary vascular resistance in patients with the heart failure. And this endothelin 1 is amongst the most potent endogenous vasoconstrictor. Right, most potent endogenous vasoconstrictor, right? And this endothelin 1 have been found to correlate with the pulmonary vascular resistance, and the plasma endothelin 1 levels, right, the plasma endothelin 1 levels, they correlate directly with the pulmonary vascular resistance, and it is thought that this peptide may also, or this peptide may play a role in mediating the pulmonary hypertension, right? This peptide may mediate, right, it may mediate the pulmonary hypertension in persons with the heart failure. So that is about the endothelin 1. Now after that, you see another question. Congestive cardiac failure is associated with increase in all of the following except right atrial mean pressure, serum sodium, urea, and then peptide. So right atrial pressure, it is elevated, urea levels, it is elevated, and norepinephrine levels are also elevated. But if you take the serum sodium levels, they are reduced. These patients with heart failure, they are associated with hyponatremia, right? And why is that they have the hyponatremia? The mechanism of hyponatremia is primary sodium gain exceeded by secondary water gain. So what is the mechanism? In patients with heart failure, there is fluid overload. Right, in patients with heart failure, there is fluid overload, and because of the fluid overload, there will be dilutional hyponatremia. Right, there will be dilutional hyponatremia. Right, in heart failure, the total body sodium, it remains same, it remains normal, or in fact, right, in fact, the total body sodium is increased. But still, why the total body sodium is increased? That is because of the activation of RAS. So once there is activation of RAS, there is synthesis of aldosterone. Aldosterone will cause sodium and as well as water retention. But here, the fluid which is retained is much more than the sodium which is being retained. Okay, and that will make the individual to develop dilutional hyponatremia, and due to which the individual will have the hyponatremia. They will not have hypernatremia, they will have hyponatremia. Okay, and so the answer is the serum sodium. Now why is that the urea will be elevated in patients with the congestive heart failure, or in patients with congestive cardiac failure, the urea levels are elevated. So why is that the urea levels being elevated? Because in patients with the congestive cardiac failure, there will be development of pre-renal type of acute renal failure. Right, there will be development of pre-renal type of acute renal failure. So because of the development of pre-renal type of acute renal failure, the perfusion to the kidney, right? What is pre-renal? Perfusion to the kidney will be reduced. So as the perfusion to the kidney is reduced, there will be increase in urea and there will be also increase in the serum creatinine. Right, there will be also increase in serum creatinine. So that is about the congestive cardiac failure. So it is associated with increase in urea, associated with increase in right atrial mean pressure, and it is also associated with increase in the norepinephrine. So if you take the other investigations in patients with the congestive cardiac failure, blood urea nitrogen, it will be elevated, and ECG is also very important. Now what is the purpose of doing the ECG? To look for the ischemic heart diseases, because coronary artery disease is one of the etiology which will cause the heart failure, and then to look for the cardiac enlargement, right, left ventricular hypertrophy secondary to hypertension that may make the individual to land up in heart failure, and to look for if there is any presence of arrhythmias causing the heart failure. Okay, so that is the importance of the ECG. Now after the ECG, the next important investigation is the imaging studies, right, that is echocardiography, right, that is echocardiography. Echocardiography, we will be able to assess left ventricular ejection fraction, we will be able to assess if there is any cardiac chamber enlargement. So echocardiography tells you about the ejection fraction, the cardiac dimensions, and if there is any presence of the wall motion abnormality. Right, and it also tells you about the presence of the valvular disease, right, and it also tells you about if there is any presence of pericardial effusion. So that is the importance of the echocardiography, and the most useful test is the echocardiography. Why? Because it will differentiate the heart failure with or without the preserved LV systolic function. So this will be able to differentiate whether the individual is having the heart failure with preserved ejection fraction or a heart failure with reduced ejection fraction. And the other important imaging study is radionuclide angiography. This radionuclide angiography also will determine the left ventricular ejection fraction of the individual. And then the myocardial perfusion scintigraphy. So these are the investigations in patients with the congestive heart failure. But out of all these, the echocardiography is a very important investigation. Then how do you treat these patients? See, the treatment, I will discuss that under two categories. One, patients with acute heart failure. So patients with acute heart failure will land up in the pulmonary edema. So how do you treat the patients of acute heart failure and how do you treat the patients of the chronic heart failure? I'll discuss both. So if you see the question, all of the following are used in the initial management of acute life-threatening cardiogenic pulmonary edema except digoxin, morphine, furosemide, positive pressure ventilation. So in acute heart failure, the life-threatening complication that can be seen is the development of the cardiogenic pulmonary edema. So what will be the treatment for this cardiogenic pulmonary edema? So first and foremost important is the oxygen supplementation. So supplemental oxygen, the maintenance of the oxygen saturation within the normal limit is important to maintain the oxygen delivery to the tissues. So you have to maintain the adequate oxygen saturation. And how will you supplement the oxygen or how will you maintain the oxygen saturation? That is via oxygen mask, right? And the second important is via non-invasive ventilation, right? Non-invasive ventilation. So this non-invasive ventilation is by the continuous positive airway pressure. So the use of continuous positive airway pressure in acute cardiogenic pulmonary edema, it is associated with significant, right? It is associated with significant reduction in the need of the tracheal intubation. So this non-invasive ventilation, it is by continuous positive airway pressure. So when you are using this continuous positive airway pressure, that led to significant reduction in the need of the tracheal intubation and mechanical ventilation. So that is about the oxygen and ventilatory support. Now next is the morphine. See, morphine, why we have, or what is the principle or what is the mechanism by which we use this morphine in acute pulmonary edema? Morphine diminishes the anxiety and decreases the sympathetic outflow. Right, decreases the anxiety and it also decreases sympathetic outflow. Now, and one more important point related to your morphine is that it will also decrease the venous return. Right, this will also decrease the venous return. So by decreasing the venous return and by decreasing the sympathetic outflow, the cardiac workload will be reduced. So that means this morphine, by decreasing the sympathetic outflow, it is decreasing the afterload on the heart, and by decreasing the venous return, it is decreasing the preload on the heart. Right, it is decreasing the preload on the heart. And once your preload and as well as the afterload is reduced, the pulmonary edema, it will get reduced. And this morphine is recommended for the treatment of acute severe pulmonary edema, especially if associated with restlessness and dyspnea effectively, and there is severe dyspnea. So mainly in individuals with restlessness, and when the dyspnea is very severe in acute pulmonary edema, this morphine is being recommended, right? What is the mechanism? It will reduce the anxiety, it will reduce the preload, and it will reduce the afterload. That is the role of morphine. Then the vasodilators. See, but vasodilators have to be given only when the blood pressure is more than 90 millimeters of mercury. And these are indicated in most patients with acute pulmonary edema. And this will be the first line therapy if associated with adequate blood pressure and signs of congestion with low diuresis. Okay, so there should be adequate blood pressure to give this particular vasodilators. Now the question is, what is the importance of these particular vasodilators? These vasodilators, let me tell you the same. They will reduce the afterload on the heart and they will also reduce the preload on the heart. And what are the examples of the vasodilators? That includes the nitrates. Right. So this particular nitrates, either sublingual nitrate or intravenous nitrate, that will be the agent of choice. And previously we were using nitroprusside, but nitroprusside is associated with cyanide toxicity, and that is the reason why the nitroprusside is not being used in the recent days. And another important vasodilator is neseritide. Neseritide, I'll explain you in detail about this neseritide. Right, I'll explain you in detail about the neseritide. So that is about the vasodilators. And next important is the diuretics. Diuretics, they are recommended for initial management of the acute severe pulmonary edema especially in the presence of the symptoms secondary to the fluid retention. So mainly to relieve the alveolar edema. Right, mainly to relieve the alveolar edema, we give this particular diuretics. And this particular diuretics which are being used is the intravenous formulations, that is the loop diuretics. And the examples of the loop diuretics that include furosemide, bumetanide or the torsemide. These are the preferred choice due to their strong and brisk diuretic effect. Then coming to the inotropic agents. So what is the purpose of the inotropic agents? The inotropic agents, they are indicated in the management of acute pulmonary edema in the presence of the peripheral hypoperfusion. So whenever there is hypotension, right, whenever there is hypotension causing hypoperfusion of the organs, that is the point when we use the inotropic agents, right? And these particular inotropic agents that includes number one, dobutamine, then followed by that, right, then followed by that the dopamine. And apart from dobutamine and as well as the dopamine, the other important inotropic agents include the phosphodiesterase inhibitors. And these phosphodiesterase inhibitors include the inamrinone and as well as the milrinone. And the next important drug is levosimendan. Right, the other important drug is levosimendan. And subsequently, the other drugs, the other inotropic agents include norepinephrine and as well as the epinephrine. So this is about the inotropic agents, right? So number one, oxygen and ventilatory support, that is very, very important to maintain the adequate oxygen saturation, and that can be achieved by oxygen mask and non-invasive ventilator. Morphine, it will reduce the anxiety and it will reduce the preload and as well as the afterload on the heart. Vasodilators, they particularly like nitrates, they will reduce both preload and afterload. Diuretics, that is the loop diuretics. Loop diuretics, they will reduce the alveolar edema. The inotropic agents, they are indicated in the management of acute pulmonary edema in the presence of the peripheral hypoperfusion or when there is the hypotension. And these inotropic agents include dobutamine or dopamine, phosphodiesterase inhibition like inamrinone and as well as milrinone, and then levosimendan, epinephrine and norepinephrine. So if you take these particular drugs, what will be the dosages of these drugs? And apart from this, the other important drug is the digoxin. Let me tell you, the digoxin, it is not given in acute heart failure. Where is this digoxin used? Digoxin is used when pulmonary edema is associated with atrial fibrillation. Right, this is used when pulmonary edema is associated with atrial fibrillation and increased ventricular rate. So in this scenario, we use this particular digoxin. Otherwise, the use of the digoxin is limited. And if you take the dosages of these particular drug, so I said you the loop diuretic, that is furosemide. The dosage is 0.5 to 1 milligrams per kg. And morphine, how much you give? That is around 2 to 4 milligrams. And oxygen intubation as needed to the individual. And nitroglycerin, if you see, sublingual nitroglycerin, right? And this sublingual nitroglycerin should be given only when the blood pressure is more than or when the systolic blood pressure is greater than 100 millimeters of mercury, right, which is a vasodilator, and the dosage is around 10 to 20 micrograms per minute. And the other important inotropic agent will be norepinephrine, and the dosage is 0.5 to 30 micrograms per minute intravenously. Or dopamine, if you see, 5 to 15 micrograms per minute intravenously. And these have to be given when the individual is having hypotension causing hypoperfusion to the organs. That is when the systolic blood pressure is less than 100 millimeters of mercury. and then dobutamine. Dobutamine dosage is 2 to 20 micrograms per kg per minute intravenously if the systolic blood pressure is 70 to 100 millimeters of mercury and there are no signs of the shock. So this will be the dosages of the drugs like what we use in the treatment of the acute pulmonary edema. Now I was discussing about one of the vasodilator, that is nesiritide. See, vasodilators, I said you one is nitrates and the other one is nesiritide. Nesiritide, right, there are some important questions related to nesiritide. Let me discuss about that. So, right, so if you take this nesiritide, the route of administration of nesiritide is intravenous route of administration, and it is a recombinant form of human brain natriuretic peptide. Right, recombinant human brain natriuretic peptide, right, and it is a potent vasodilator. Now because it's a potent vasodilator, it reduces the ventricular filling pressures and improves the cardiac output, and its hemodynamic effects resembles those of the intravenous nitroglycerin with a more predictable dose response curve and longer duration of action. Okay, so the action is similar to that of sublingual nitrates, but the additional advantage is it has longer duration of action. Right, it has longer duration of action and more predictable dose response curve. Right, more predictable dose response curve. And in clinical studies, nesiritide is administered at a dosage of 2 micrograms per kg. Right, it is administered at a dosage of 2 micrograms per kg, and the route of administration already I have said you, that is intravenous. So 2 micrograms per kg is intravenous bolus. Right, so this will be the bolus dose, and this bolus dose, it is followed by the infusion, and this infusion is given at 0.01 micrograms per kg per minute. Right, 0.01 micrograms per kg per minute, and this may be titrated or this may be up titrated if needed. And this particular nesiritide, it produces rapid improvement in both dyspnea and as well as the hemodynamics. Right, rapid improvement rapid improvement in dyspnea and as well as the hemodynamics. So that is about the treatment of the acute pulmonary edema. So all of the following are used in the management of acute life-threatening cardiogenic pulmonary edema except digoxin, morphine, furosemide, positive pressure ventilation. So digoxin is not used in the acute cardiogenic pulmonary edema. When do we use digoxin? We use digoxin when the acute heart failure is associated with atrial fibrillation and increased ventricular rate. That is the point when we use digoxin. And let me tell you, whenever you use digoxin, digoxin is associated with the digoxin toxicity. When digoxin is being used for longer duration in increased doses, the individual will end up in digoxin toxicity. And the earliest feature of digoxin toxicity is nausea and vomiting. But this digoxin toxicity, it is associated with arrhythmias. So if you see the arrhythmias in digoxin or digitalis toxicity, It is commonly associated with atrial arrhythmias and it is commonly associated with ventricular arrhythmias. And if you see the atrial arrhythmias that you will have in patients with the digoxin toxicity, these atrial arrhythmias, they include sinus bradycardia or sinus tachycardia, and they can also develop first degree AV block. Right? They also develop the first degree AV block. And not only first degree, there can be even second degree AV block, and there can be also development of the third degree AV block. And the atrial arrhythmias, these arrhythmias could be either bradyarrhythmias or tachyarrhythmias. So they include development of either sinus tachycardia or development of sinus bradycardia. Right? So this will be the atrial arrhythmias. And then if you take the ventricular arrhythmias with digoxin toxicity includes the ventricular premature contractures, there can be ventricular tachycardia, and there can be development of the ventricular fibrillation. And the arrhythmias which are not associated with digoxin toxicity, that includes the atrial flutter. In fact, for the treatment of atrial flutter and as well as atrial fibrillation, we use the digoxin. So these two arrhythmias are not associated with digoxin toxicity. And the other important arrhythmia which is not associated with digoxin toxicity is Mobed's type 2 AV block. Right? Mobed's type 2 AV block. So these are the arrhythmias which are not associated with the digoxin toxicity. So apart from arrhythmias, what are the chronic digitalis intoxication associated with? So it is characterized by the development of nausea and vomiting. I said you this particular nausea and vomiting, these are the earliest manifestation in patients with the heart failure. Then followed by that, there will be development of the weight loss. There can be development of gynecomastia, right? And there can be development of yellow vision, right? And lastly, the individual will also have delirium. So these are the manifestation of the digitalis intoxication. Then how do you manage, right? How do you treat these particular digoxin overdose? First and foremost, the withdrawal of the drug. Right, first and foremost, withdrawal of the drug. And then you need to supplement the potassium. Right, you need to supplement the potassium. This potassium is administered cautiously and by oral route. And this potassium is supplemented, particularly if hypokalemia is present. Why? Because hypokalemia will precipitate the digoxin toxicity. And you need to treat the arrhythmias, that is ventricular arrhythmias or the atrial arrhythmias. So if it is like tachyarrhythmias, if it is like digitalis induced ventricular tachyarrhythmia, the drug of choice will be lidocaine. Right, so lidocaine is effective in treating the digitalis induced ventricular tachyarrhythmias. And for suppose if the individual has developed complete heart block, right, if the individual has developed complete AV block, then the individual has to be placed on the cardiac pacemaker. Right, has to be placed on the cardiac pacemaker. And apart from this, if the individual is hemodynamically unstable, right, so if the individual is hemodynamically stable in the ventricular arrhythmias, we give lidocaine. But if the individual is like hemodynamically unstable, then we do electrical cardioversion. right? We do electrical cardioversion. This electrical cardioversion may be life-saving in digitalis induced ventricular fibrillation, who is hemodynamically unstable, and in potentially, right, in potentially severe intoxication, right, in potentially severe intoxication, these patients, they require the digibind, that is digitalis antibodies. And these digitalis antibodies, they include FAB fragments. Okay, so that is about the drug what we give when there is severe intoxication. So that is about the treatment of acute pulmonary edema. In acute pulmonary edema, oxygen supplementation is important, loop diuretics, then vasodilators like nitrates and as well as necitide, then morphine. Next, depending upon the requirement, the inotropes. So this will be the treatment for your acute life-threatening pulmonary edema. Then how do you treat the chronic heart failure? So if you see the question here, what are the drugs used in the heart failure? That is the AC inhibitors, hydralazine, calcium channel blockers, carvedilol, and then chlorthalidone. So you need to remember that, always remember these important points about the management of the heart failure. Once the clinical diagnosis of heart failure is confirmed, you need to assess, is there any fluid retention or not? And it is important to treat the patient's fluid retention before starting AC inhibitor or angiotensin receptor blocker. And even you take the beta blocker. Beta blocker should be started once the fluid retention has been treated. So if you see this flowchart, right, I'll come back to this question after the discussion. Right. So you see this flowchart. So once the diagnosis of the heart failure is confirmed, first important thing is you need to assess the fluid retention. Is it present or absent? If there is fluid retention, don't give beta blockers or ACE inhibitors. First you need to give diuretics. And if there is no fluid retention, then you need to give the ACE inhibitors or the beta blockers have to be given. Now with ACE inhibitors and beta blockers, if the individual symptoms, if they improve, then we continue the same ACE inhibitors and beta blockers. But if there is persistent symptoms, then the additional drugs that you need to add is ARBs. But when you are giving ACE inhibitors, you should not give ARBs, angiotensin receptor blockers, because that will cause potent hyperkalemia. Right? Both, if you are using ACE inhibitors and ARBs, that will cause hyperkalemia and can make the individual to land up in mortality. And the other drugs that can be added is the aldosterone antagonist, that is spironolactone, hydralazine, which is an arteriolar vasodilator, then isosorbide and as well as digoxin. So these drugs have to be added when the symptoms are persisting in spite of your ACE inhibitors and as well as the beta blockers. And what about this ICD and CRT? ICD stands for implantable cardioverter defibrillator. CRT stands for cardiac resynchronization therapy. So these are the devices. I will discuss that where we require devices in the treatment of congestive heart failure, right? I'll discuss even that as well. Now, if you summarize, right, if you summarize the drugs used in the heart failure. So if you see the classification of the drugs used in heart failure, drugs which help in relieving the congestive or low output symptoms and restoring the cardiac performance. So what are the drugs which will help in relieving the congestion? Number one, the diuretics. So they will reduce the congestive symptoms and they restore the cardiac performance within the individual. And these diuretics include the loop diuretics like furosemide, torsemide, bumetanide, and then metolazone. And the other group of drugs are vasodilators. Right, the other group of drugs are the vasodilators, and these particular vasodilators include nitrates and necitide. And the inotropic agents. And these inotropic agents include digoxin, dopamine or dobutamine, milrinone, and then levosimendan. And then we have the drugs which will increase the blood pressure and maintain the blood pressure within the individual. That will be vasoconstrictors. And these particular vasoconstrictors, they include the norepinephrine and then epinephrine, then phenylephrine or vasopressin. So these are the drugs which will relieve the congestion or which will relieve the low output symptoms, and they will restore the cardiac performance within the individual. And if you see the drugs which help in arresting or which help in reversing the disease progression and prolong the survival, that means these are the group of drugs which will reduce the mortality, right, which will reduce the mortality within the individual. And these drugs which will reduce the mortality in the individual is the ACE inhibitors, or the angiotensin receptor blockers, right? And the second group of drugs are the beta blockers, right? The second group of drugs are beta blockers. And what are the important beta blockers which will reduce the mortality is bisoprolol, then we have metoprolol, then we have carvedilol. So these are the beta blockers. Then followed by that we have aldosterone antagonists. Right, and these aldosterone antagonists that include the spironolactone and as well as the eplerenone. So these are the drugs which will arrest or reverse the disease progression and will prolong the survival within the individual. Now followed by that, if you see the next question, treatment of choice for patients with congestive heart failure and ejection fraction less than 40% is ACE inhibitors plus beta blockers, ACE inhibitors plus diuretics, ACE inhibitors plus angiotensin receptor blockers, and ACE inhibitors and then calcium channel blockers. So in heart failure with reduced ejection fraction, the very important group of drugs that need to be given is the ACE inhibitors plus beta blockers. And whenever you are giving these beta blockers should be initiated at lower doses than effective doses in congestive cardiac failure. So these beta blockers, they should be initiated at low dose, right? They should be initiated at low dose followed by gradual increment in the doses, right? Followed by gradual increment, right? Followed by gradual increment in the dose. And when will you increase the dose? That is, if lower doses have been well tolerated, right? That is, if lower doses, if they are well tolerated, that is the point when you need to step up or you need to increase the dosage of the beta blockers. And the dose of beta blockers should be increased until the doses used are similar to those have been reported effective in the clinical trials, right? And the titration, see, you need to step up if the lower doses are tolerated, and the titration of the beta blockers should proceed no more rapidly than a 2 weeks interval. So that gradual increase in the dose should be at least a minimum of, right, a minimum of 2 weeks interval period, because the initiation and increasing the doses of these agents may lead to worsening fluid retention. Why? Because they will reduce the heart rate and that will increase the LV end diastolic volume and that will increase the fluid overload. So in order to avoid that, you need to start with the low dose. If the individual is tolerating, after 2 weeks interval, you can gradually step up this particular beta blocker, right? And when you directly give very high dose where the individual is not tolerating, that can lead to worsening fluid retention, right? And very important point is, whenever you are giving the beta blockers in NYHA class 3 and class 4, a special precaution should be taken, right? So a special precaution should be taken when you are giving this beta blockers in NYHA class 3 or NYHA class 4, right? Although data suggests that patients with NYHA class 3 and class 4 CHF may tolerate the beta blockers and benefit from their use, this group of patients should be approached with considerable caution, right? They should be approached with considerable caution. And what are the preferred beta blockers? Just now I have said you, carvedilol, metoprolol, and as well as the bisoprolol. These are the preferred beta blockers in the congestive heart failure, out of which you take the metoprolol. This metoprolol, it is a beta 1 selective agent. Right, this will be the beta 1 selective agent. Then followed by that, if you take the carvedilol, carvedilol, it is a non-selective third generation beta blocker. Right, non-selective third generation beta blocker. So that is about the carvedilol, right? So if you see a question on the beta blocker therapy in congestive heart failure, all of the following are true about starting beta blocker therapy in cases of congestive heart failure, except the options are: they should be initiated at the effective doses, they should be gradually increased over weeks, special precaution should be taken in NYHA class 3 and class 4, carvedilol and metoprolol are the preferred drugs. So what is the question? The question is except, that is, which is the incorrect statement. They should be initiated at effective doses. That should be the incorrect statement about the beta blocker therapy in patients with the congestive heart failure, right? And then followed by that, in patients with heart failure with reduced ejection fraction, I said you one important combination, that is, the important combination in heart failure with reduced ejection fraction is the ACE inhibitors plus beta blockers. Now the question is, what is the importance of these ACE inhibitors and beta blockers, right? Why you have to give ACE inhibitors and beta blockers in patients with the congestive heart failure? See, in the beginning I said you that in patients with congestive heart failure, there is activation of the compensatory mechanisms. Right, there is activation of the compensatory mechanisms. And what are the activation of compensatory what are those compensatory mechanisms activated? Increase in the sympathetic nervous system outflow, and then activation of RAS, right? And then activation of RAS. So now these compensatory mechanisms, I said you, they are only transiently useful, right? Only transiently useful. Why? Because these compensatory mechanisms, whenever they are activated, you know, they will increase the afterload, right? They will increase the afterload on the heart, and that will precipitate the heart failure. So these compensatory mechanisms should not be in active state for a long-term period in patients with heart failure. So you need to neutralize or you need to nullify these compensatory mechanisms. So for neutralizing the sympathetic effect, we give beta blockers. For neutralizing the RAS, we give the ACE inhibitors. So that is the purpose of giving the ACE inhibitors and as well as the beta blockers in patients with the congestive heart failure, right? And let me tell you that in patients with the congestive heart failure, that is in heart failure with reduced ejection fraction, in the recent days, a new molecule have come to improve the ejection fraction of the individual. See, previously what we were using this ACE inhibitors and beta blockers, but the present molecule which is being added is, the present molecule which is being added is combination of the sacubitril and as well as the valsartan. So the most recently approved medication to improve the clinical outcome in patients with heart failure with reduced ejection fraction, it is the combination of the valsartan and sacubitril. And this particular valsartan, it is an angiotensin receptor blocker. And if you take the sacubitril, it is a neprilysin inhibitor. Right, it is a neprilysin inhibitor. So compared to your ACE inhibitors, enalapril and beta blocker, this particular ARNI, what do you mean by the word ARNI? ARNI stands for angiotensin receptor blocker neprilysin inhibitor. That is what is your ARNI. So compared to your ACE inhibitor plus beta blocker, ARNI, it has been shown to reduce the cardiovascular death. Right, this has been shown to reduce the cardiovascular death and this has been shown to reduce the hospitalization as well. Right, this has been shown to reduce the hospitalization for heart failure by 20% of patients. And the trial, right, the trial which has used this ARNI and proved that it will improve the ejection fraction is the Paradigm HF trial. Right, that is Paradigm HF trial. So according to this Paradigm HF trial, the cardiovascular death itself was also reduced by 20%. Right, so cardiovascular death, it is reduced by 20%. Right, so that is about the advantage of the sacubitril and as well as the valsartan. And even according to American College of Cardiology or American Heart Association, this sacubitril and as well as valsartan, it is class 1 recommendation. Right, it is a class 1 recommendation in patients with heart failure with reduced ejection fraction. Okay. Next, after the sacubitril and valsartan, the other important molecule which have been used in the treatment of heart failure are the following. That is SGLT2 inhibitors. See, what are these SGLT2 inhibitors? These are the oral hypoglycemic agents used in type 2 diabetes mellitus. Right, used in type 2 diabetes mellitus. Large clinical trials of patients with type 2 diabetes mellitus have shown that the inhibitors of the SGLT2 reduce the risk of hospitalization for heart failure. Right, so these drugs, they will reduce the risk of hospitalization for the heart failure. Okay, that is the importance of the SGLT2 inhibitors. And what are the examples of this SGLT2 inhibitors? That includes dapagliflozin. So dapagliflozin reduced the risk of hospitalization for heart failure and cardiovascular deaths. Right? And this is given in patients with heart failure and reduced ejection fraction. So this is a preferable drug in heart failure with reduced ejection fraction with or without diabetes mellitus. Right, with or without diabetes mellitus. Thus, for patients with diabetes at risk for heart failure, SGLT2 inhibitors may be a good choice. And for patients without diabetes, with heart failure with reduced ejection fraction, dapagliflozin right? This dapagliflozin has FDA approval to improve the clinical outcome within the individual, right? So that is about your SGLT2 inhibitors. Next, the other important drugs are the ivabradine. So if you take this ivabradine inhibits the funny current channels, right? So right, it inhibits funny current channels in the sinus node, right, in the sinus node, and this ivabradine has the specific effect on the slowing the sinus rate. Right, so when there is sinus tachycardia, this ivabradine is approved by FDA for use in stable patients with heart failure and heart rate of 70 beats per minute. Right, so who are like taking maximally tolerated dose of beta blockers, or in patients in whom beta blockers are contraindicated, you can give this ivabradine. Okay, so this is given in patients with contraindication to beta blockers. Okay, that is the importance of ivabradine, but this ivabradine is given only when there is sinus tachycardia. So after having discussed about the entire medical management, let me just give you a flow chart, and I will also discuss about the interventions in the congestive heart failure. So this is the important flow chart. So step 1, you should establish the diagnosis. That is, establish diagnosis of heart failure with reduced ejection fraction. If it is there, what is the first drugs that we need to start? ACE inhibitors or the angiotensin receptor blockers, and to this the beta blockers should be added, and diuretics should be added as and when needed. And when you are giving these ACE inhibitors plus beta blockers or ARBs plus beta blockers, step 2, you need to consider the following patient scenarios. That is, if the individual is in NYHA class 2 to class 4, right, NYHA class 2 to class 4, and the creatinine clearance is more than 30 and potassium levels are less than 5 milliequivalents per liter, you need to add the aldosterone antagonist. And you take the second scenario, the patient is in NYHA class 2 to class 3 heart failure, the blood pressure is adequate on ACE inhibitors or angiotensin receptor blocker, and there is no contraindication to ARBs or sacubitril, then discontinue ACE inhibitors or the beta blocker. Then you need to initiate the ARNI. What is ARNI? That is angiotensin receptor blocker, that is valsartan. NI stands for neprilysin inhibitor, that is sacubitril. Then NYHA class 3 to class 4 in black patients, you need to give the hydralazine and nitrates, right? And NYHA class 2 to class 3, where the ejection fraction is less than 35%, more than 40 days post myocardial infarction, very, very important point. Heart failure with reduced ejection fraction, NYHA class 2 to class 3, and post myocardial infarction after 40 days, you need to put the patient on ICD, implantable cardioverter defibrillator, because that will reduce the development of arrhythmias, right? And other scenario is NYHA class 2 to 4 with ejection fraction less than 35% and QRS complex more than or equal to 150 milliseconds, right? QRS complex more than or equal to 150 milliseconds with left bundle branch block pattern. In these patients, they have to be placed on CRT, cardiac resynchronization therapy. This cardiac resynchronization therapy will improve the synchrony between the ventricles and improve the cardiac output. And this is placed mainly in individuals where the individual has heart failure with reduced ejection fraction secondary to dilated cardiomyopathy with QRS complex more than 150 milliseconds. Right, and the last important clinical scenario is NYHA class 2 to class 3 normal sinus rhythm, the heart rate is more than 70 beats per minute on maximally tolerated beta blocker. For them you need to give the ivabradine. So depending upon the clinical scenario you need to add the medications. And class 3 and step 4 is that you need to reassess the symptoms, and if the individual is refractory, that means you have done all the medical management but still the individual is refractory. If the individual is refractory, the only option which is left out is the palliative care. Transplantation is another option. LVAD, left ventricular assist device, is another option, and investigational studies. But if the individual is improving the symptoms are improving, no problem, but the individual is refractory to the symptoms, only the palliative care, the transplant is one option, and LVAD, that is left ventricular assist device. So this is about the treatment of the congestive heart failure. Particularly in this, what I have taken is heart failure with reduced ejection fraction, right? And I'll show you one more question. The image shows the presence of implantable cardioverter defibrillator, cardiac resynchronization therapy, dual pacing, transvenous pacemaker. So if you see the image, what is that you are able to make out in this image? You have one lead in the right atrium, you have another lead in the right ventricle, and another lead is present in the lateral wall of the right ventricle. The options are implantable cardioverter defibrillator, cardiac resynchronization therapy, dual pacing, transvenous pacemaker. The answer in this question is cardiac resynchronization therapy. See, in cardiac resynchronization therapy, you have the presence of three leads. One is in the right atrium, the other is in the right ventricular apex, the third is in the lateral wall of the left ventricle. And this strategy is useful for patients with dilated cardiomyopathy and congestive heart failure. Right, this strategy is useful for patients of dilated cardiomyopathy and congestive heart failure where the right and left ventricles do not contract simultaneously but there is asynchronous contraction. In them we use this CRT, cardiac resynchronization therapy. So this resynchronization therapy, it will improve the symptoms. Right, it will improve the symptoms within the individual. And when is that you need to consider for the cardiac resynchronization therapy? That is when the QRS complex is more than 150 milliseconds, right, when the QRS complex is more than 150 milliseconds with left bundle branch block, or you need to consider the CRT when the QRS complex is more than 120 milliseconds and ejection fraction less than 35% within the individual, and where the individual is having severe symptoms despite optimal therapy. That is about your CRT, that is cardiac resynchronization therapy. And next important intervention is ICD, that is implantable cardioverter defibrillator. See, this implantable cardioverter defibrillator, this will benefit the patient, right? This will benefit the patient from sudden cardiac death, right? This will benefit the patient from sudden cardiac death, right? Mortality benefit in primary and secondary prevention of the sudden cardiac death. So that is about the procedural intervention. And we have the life-saving procedures if the individual is like refractory to all these, right? And what are the options which are left out? We have discussed, that is LVAD or RVAD, that is left ventricular assist device or right ventricular assist device, and then the cardiac transplantation. Some non-medical management, one is your intervention, and apart from that the dietary supplements like the fish oil. See, treatment with long chain omega-3 polyunsaturated fatty acid, right? Long chain omega 3, right, long chain omega 3 polyunsaturated fatty acid, they have been shown to be associated with modestly improved clinical outcome. Right, they will improve the clinical outcome in patients with heart failure with reduced ejection fraction. So that is about the fish oil. And one of the recent therapy is EECD, that is enhanced external counter pulsation technique. See, this EECD, what you need to do is peripheral lower extremity therapy using graded external pneumatic compressions at high pressure is administered. Okay, so these are, right, these are pneumatic compression devices. Right, these are the pneumatic compression devices. Okay, see, these pneumatic compression devices, they are administered at high pressure in 1 hour sessions for 35 treatments, right? So they have to be administered in 1 hour sessions for 35 treatments. Okay, so you have to administer this 35 cycles for over 7 weeks. And this treatment have been proposed to reduce the angina symptoms and extend time to exercise induced ischemia in patients with the coronary artery disease. Now, what does this EECP do? What is the mechanism? In what way it helps in patients with the congestive heart failure? See, the mechanism is similar to that of the intra-aortic balloon pump. What does that EECP do? EECP is administered like where the vigorous pressure is administered over the vessels by the blood pressure cuffs during diastole. Right? So if you see this, these are all the blood pressure cuffs. Right? These are all the blood pressure cuffs. What these blood pressure cuffs do? They will apply the pneumatic compression to the vessels mainly during the diastole. So thereby what will happen? When you apply the pressure during diastole, there will be increase in the pressure within the aorta. Once there is increase in the pressure within the aorta during diastole, the coronary perfusion increases. Now as the coronary perfusion increases, there will be improvement in the myocardial viability, right? So this EECP, right, this EECP, it improved exercise tolerance. Right, it improved exercise tolerance and it also improved quality of living and NYHA classification, but without an accompanying increase in peak oxygen consumption. This EECP will improve the quality of life. It will also improve, right, will also improve the NYHA functional classification, and it also improved the exercise tolerance, but without an accompanying increase in the peak oxygen consumption. So that is about your EECP, that is enhanced external counter pulsation techniques. Next, you see a question here. A 56-year-old patient with stage D ischemic cardiomyopathy comes to you for a second opinion. He is already receiving furosemide, ACE inhibitor and beta blocker and spironolactone. He has been told by a specialist that he needs a device to avoid dying from an irregular heart rhythm. What non-pharmacological treatments are available for prevention of sudden cardiac death in patients with ischemic cardiomyopathy? Ventricular assist device, implantable cardioverter defibrillator, biventricular pacemaker, intra-aortic balloon pump. The answer in this question is the ICD, that is implantable cardioverter defibrillator. So this implantable cardioverter defibrillator, that will prevent or that will inhibit the arrhythmias secondary to ischemic cardiomyopathy and thereby preventing the development of the sudden cardiac death. Now, one more clinical question if you see. A 55-year-old patient of yours presents for routine follow-up of the congestive heart failure. An echocardiogram done 6 months ago showed left ventricular ejection fraction of 20%. He feels quite well, has unlimited exercise tolerance while exercising on flat ground and has dyspnea only with climbing more than 2 flights of stairs. His current regimen is enalapril 40 milligrams per day, furosemide 40 milligrams twice daily. On physical examination, his blood pressure is 135 by 80 millimeters of mercury. Pulse rate is 88 beats per minute and respirations are normal. The rest of his examination is remarkable only for moderate obesity, 1 plus pretibial edema. He has heard that medications called beta blocker could be helpful for people with heart trouble and wonders if he should be taking them. Which of the following statements regarding the beta blocker use is true? So basically the question is about like the beta blockers. First option, beta blockers are contraindicated in patients with congestive heart failure. Second option, beta blockers are contraindicated in this patient because his ejection fraction is so severely diminished. How much is the ejection fraction? 20%. Third option, beta blockers are not indicated in this patient because his blood pressure is already well controlled. Fourth option, beta blockers are not indicated in this patient because his congestive heart failure is controlled by his current therapy. And fifth option, beta blockers are indicated in this particular patient. Let me tell you, in heart failure with ejection fraction and with a blood pressure of 135 by 80 millimeters of mercury, beta blockers are indicated in this patient. Right? So beta blockers and as well as AC inhibitors or ARBs, they will improve the survival of the individual with heart failure with ejection fraction. So that is about the treatment of congestive heart failure. Now let me tell you some of the essentials of diagnosis of acute heart failure. That means these are synopsis points. Acute onset or worsening of dyspnea at rest, it is a very important feature of the acute heart failure. These patients with acute heart failure, they have tachycardia, diaphoresis and as well as cyanosis. And because of pulmonary edema, they have pulmonary rales, rhonchi and expiratory V's. And radiograph of these patients with acute heart failure, they show the interstitial and alveolar edema with or without cardiomegaly. And there will be arterial hypoxemia because of the pulmonary edema. So these are the important points related to your acute heart failure. And if you see some important points related to chronic congestive heart failure, it is chronic congestive heart failure, it is either systolic or diastolic heart failure, right? And the predominant symptoms are those of low cardiac output, there will be congestion including the dyspnea. These will be the features because of LV failure. And if you see the features due to RV failure, symptoms of the fluid overload, they predominate. And there will be pedal edema, there will be ascites and there will be facial swelling as well. And assessment of LV function is a crucial part of diagnosis and management. And optimal management for chronic heart failure indicates combination medical therapies such as ACE inhibitors, aldosterone antagonist and as well as the beta blockers. So ACE inhibitors, ARBs, beta blockers, aldosterone antagonist, they will inhibit the cardiac remodeling and they will improve the survival in patients with the congestive heart failure. So these are some of the important points regarding this topic of congestive heart failure. Thank you very much.